Okay, Mark, so I know you very well, you know me very well, but just for the benefit of those who might be the first time they're looking at this infocast, in the context of the pandemic, vaccines and pulmonary hypertension, can you just introduce yourself so people know who we're speaking with?
So I'm Mark Toshner. I'm a lecturer in Cambridge, and I work in the pulmonary hypertension unit here. And for the last year and a half, I've been working in vaccine trials. So we've had a couple of these calls to kind of answer and go over some fairly basic information gaps, I think, that have been out there. And we might touch on what I've been doing in the last 4 months at the end. I haven't really talked to you about this much, but I'm the chief investigator of the world's biggest post-hospital long COVID trial.
Right.
Called Heal COVID, and if you want to talk about long COVID and how it might, interact with our patient population, I'm happy to do that as well. No,
that'd be good. That'd be a good opportunity, Mark. So, just in the context of where we're at the moment, we're in the week of which Freedom Week, restrictions were lifted, whatever Freedom Week means. So, a very broad question, Mark. How do you, or where do you think we are? What's your feeling about where we're at in the pandemic? Because we're still in pandemic times and that, but where are we now compared to where we were at the beginning of the pandemic or when we first talked, which was about 6 months into pandemic? Your overview.
Okay, so the short summary is the vaccines are rolled out now, and as we thankfully talked about in the first couple, safety has been pretty good. And coverage has been fantastic, and we know that the actual program went very well for the first half of the year. So all of our vulnerable patients are vaccinated, and I haven't come across a patient in clinic who hasn't been double vaccinated in the last couple of months. So that's fantastic. The downside is the virus hasn't sat still either, and has mutated again. And the latest variant, the Delta variant, is more transmissible, and so we're now kind of fighting against a wave of more transmissible version of our old foe now, and that's happening with mixed results. I think the vaccines have done a really brilliant job in limiting the amount of people that have ended up in hospital or who've died from the disease this time round. So that's really clear, and that's unequivocal. The downside is this wave is still big because there are quite a lot of people who aren't vaccinated around the country, and that is largely what's propagating the spread. The other thing to remember is the vaccines, although really, really effective, are not 100% effective. So there are still double vaccinated patients who are succumbing to disease and being hospitalised. So it's a bit of a period of equipoise because we've got a lot of cases around us. It's not translating to the same burden in hospitals as last time. It's therefore a good position, but there's risks ahead. And one of those risks is that word freedom, which I think, it's an unfortunate label to have given to this point in the pandemic, because it hasn't gone anywhere, it's still there, and we still need to kind of pay attention to it and think about what our own responsibility is.
Oh, what makes the virus, because you say it's more transmissible, so it's easier to pass on. Why might a virus be easier to pass on? Surely a virus is a virus and it's a virus.
So that's what they do. They're quite clever. They react and they evolve just like we do, but they do it just much quicker. So they are evolving to the circumstances that are happening around the globe of an increasing proportion of people who are immune because they've had the disease and because of the vaccine. So it then creates an environment where any variant that has a competitive advantage will take hold. And that's exactly what we've seen. We had what got renamed the Alpha variant, and it was our dominant variant until about 6 weeks ago. But because there's a competitive advantage with the Delta variant, which grows faster, it's just taken over. A little bit like weeds in your garden. So right. It's like a very effective weed that, given the right circumstances, has just flourished.
And are the vaccines that we have at the moment less effective, more effective, not effective with these variants?
Brilliant question. There was a really recent paper that answered this exact question, came out yesterday, in fact, in the New England Journal, from real world data from the UK, including some of the data from our genetic surveillance program. So in very big numbers, so pretty definitive, probably the best bit of evidence we've got yet. And what that shows is there's a big impact on single vaccinated people. So the single vaccinated people, the effectiveness of the vaccine is down at 30-40%, depending on which vaccine you look at. The effectiveness of double vaccinated people is held up, but it's not as high as versus the original variant. So AstraZeneca and Pfizer, there are subtle differences again between the two. They're still 60% plus effective, so that's still good. I think Pfizer sat at about 80, but they're not sitting in the 90s for preventing infection. Now, they're still doing a good job of preventing hospitalization, but it does appear that this vaccine is a little bit better this virus variant is a little bit more effective at evading the vaccines, not completely, but the effectiveness is slightly reduced.
Because you said something there, Mark, and I think we're all learning this, that we're all become experts in vaccines, or because we're all experiencing in some ways that a vaccine doesn't necessarily prevent the disease occurring, but it can lessen the impact of the disease in the individual. Is that right?
Yeah, that's right. And that's one of the important goals of a vaccine, is to reduce complications or to reduce serious sequelae of the infection. And that's still happening. There's no question about that. And you can see that in the numbers that have been admitted to hospital, because about 90% of the adult population, depending how you define adult, have been vaccinated. And so if the vaccines had no effect, then you'd expect the proportion of patients to be admitted to hospital to be the same. In fact, it's down at 40%. And that's an even bigger effect than it appears on the face of it, because when you think about that 10% of people who aren't vaccinated, they're in fact responsible for 60% of the admissions. So you have to multiply everything by the fact that those people are almost 10 times as infrequent as the vaccinated people, but are still accounting for the vast majority of cases. So that's all very positive.
What about you? Because you mentioned the difference between single vaccinated people at the moment, double vaccinated people, impact of there's obviously now in the preparing for what people are describing a booster vaccine for those who are being deemed to the value of that, who are going to be the people that need the booster vaccine, Mark?
Okay, so good question. And at the moment, we don't really know the answer to it. So I'm sitting in the data safety committee for that trial, in fact, for one of those trials, the big trial of booster vaccines. And we don't have data through, and so it also wouldn't be appropriate for me to talk about it. We'll find that out soon. So we'll see that in the next month or so. We'll get some answers on that. And it's not going to be a definitive answer of yes or no. It's going to be an evolving picture of when a booster is best given, who it's best given to. And so I don't think we're going to get a single point where we get absolute clarity on what we do with boosters. They're going to come in, I think, in the winter. And they'll probably come in initially for restricted populations that will then be rolled out as the evidence changes. But my expectation, and I think I said this at the start actually, so I think I've been pretty consistent, is that we're going to need boosters. That was all.
Yes, you did. Yeah. And will the booster? Is the idea of the booster to give stronger protection or just longer protection, if that makes sense as well? So this is. Yeah. We need it for longer, or it's more powerful if you have a third dose.
Yeah, Ian, I love it when you've got your eye on the ball. That is the question, isn't it? And in fact, actually, eventually we'll be addressing both. And the variant boosters will become the dominant boosters. So I don't doubt for a minute that the booster you get will not end up as the same vaccine you started with. It'll be a booster to one of the new variants. And so that the point of that is to try to improve protection, but also to make it for a longer period.
Okay, and these are just sort of questions that come to mind as well. But will the booster be so? For example, I've had the AstraZeneca. Will I, if I'm deemed to be the person who needs a booster, because I'm a lot older than I look, I know I look 30,
at least in your 30s, yeah.
Older. Will I need the same? Because when I had the first and second, I needed the same. Will the booster be the same, or is that still open to decision making?
So the last data safety committee I sat on was for the heterologous dosing trial, and I think we might have touched on that last time. That is when you mix and match. And what that's shown is that mixing and matching is at least as good as sticking with the same vaccine, and might be better in some circumstances. So I would expect when it comes to boosters, it's not going to be a case of restricting it to the same vaccine. It'll really just depend what we've got in decent quantities, and it's safe to mix and match them. We now know that. So my expectation is it will just be a kind of utilitarian approach to whatever we've got the most of and we're able to get in arms as fast as we can.
So I think that's reassuring to know that it is safe. You did touch upon that, Mark, last time, because I think you also alluded potentially in the context of moving forward in for the next few years that the variants might be more, we might get better protection if we mix and match, or have I misunderstood what you might have said?
Yeah, that's exactly right. And right. that appears to be the case. So the data was published last month in the Lancet, and so the early data in that is backing up that idea. It does look like if you mix your vaccines, you might get a better response. It's not proven yet, and it's not proven that then results in less infection. And so right. we will be watching that with time now. But I think the idea is still in there. But most importantly, I think the really important takeaway from this is just that mixing and matching is almost certainly no worse than getting the same vaccine, and maybe better.
Okay, just talking about different, like we talked about booster there. One of the other things very much in the media at the moment, in the context of pulmonary hypertension in some of our population, children and vaccines. What would you like to say about that, and safety, and who should, and those sorts of things?
Okay, so I think this is difficult. It's difficult, but you could view it really simply. And so I'll give you the simple version, and then I'll give you the longer one. The simple version is that even though children are low risk, and that is more if you're healthy, less so if you've got comorbidities or if you've got additional health problems, but they're still low risk. Healthy children are very low risk. Even though we know that, there are still risks. There are both risks of hospitalization, of rare deaths, and of long COVID. And so the vaccines, from the data that we have, carry some risks. And the big notable one is the myocarditis. But that's about 1 in a million, and as we understand it at the moment. And some of those complications of the COVID are much more frequent.
What's myocarditis, Mark? I mean, is that serious?
So that's inflammation of the heart, and it can be serious, but so far all of the reported cases have been self-limiting, so haven't required any severe intervention, and to date, as far as I am aware, nobody's died from it. But it's there, and it's a risk, and the benefit for children is smaller, so it is important that we acknowledge that. But the risk benefit is still in favour of having the vaccine. So the simple way of looking at this is, okay, I acknowledge there's a small risk, maybe 1 in a million of a serious complication, but there are still some benefits, and the benefit scenario is still in favour of the vaccines. It's not as clear as in the adults, where there's clear daylight in the benefit, but it's still there. So you could just say, okay, fine, they're safe, and so we give it. But the more complex picture is that there is I think an ethical dimension to this, and I can't remember if we talked about that last time, but we've got vaccines supply that's limited around the world, and I personally think it's a morally questionable decision for us to be going after very low risk groups, whilst my colleagues in places like Uganda and vulnerable people with pulmonary hypertension around the world haven't come near a vaccine yet. And I think we need to be marshalling vaccine supplies to do the best for the whole world and not just our bit of it. So there's that part of it. If you don't buy that argument, actually we don't have a lot of supply in the UK right now, although the government's been a bit opaque about the numbers. The best estimates suggest we probably couldn't vaccinate all the kids right now. So we're probably going to have to wait anyway, even if we wanted to. The last part of it is consent, and consent is tricky with kids, and most of us probably haven't given it a lot of thought. As a parent, you probably think you're going to do the consent for your children, but actually for a lot of them, you're not. And so if your child is between 16 and 18, they can consent from themselves, for example. Teens have mechanisms of consent whereby if they're capable, they also can consent for themselves. And I think a lot of people haven't thought through the ramifications of how we do this in the clinic. I personally, as a parent want to be involved in that decision. So there are some things for us to wrinkle out, for some wrinkles for us to address and to think about how it gets practically rolled out so that parents are happy and that children don't lose their autonomy where it's appropriate. So I think the overall issue is very complex. It's a little bit of a red herring right now because I don't think have the vaccine stocks to do it in the next few months. I think we need to be getting prepared to vaccinate our children, and we'll probably start doing that later in the year or next year. I think we need to think about how we want consent to work in our own families. Are you happy? Have you had a conversation with your children, for example, about whether they want the vaccine? And then beyond that, I think we should be putting pressure on the government to have equity of access to vaccines embedded in our policies around the world. And that might be a bit idealistic, but it's where I sit.
Well, I wonder if it is idealistic, Mark, because I've sort of been struck by a number of things. I'm sort of involved with doing some fundraising for this vaccine aid thing, which is back with UNICEF and stuff like that. And I mean, it is true, isn't it, that we're not safe till all of us are safe, and it's a global pandemic. By definition, it is that. So, well, this is about keeping everybody safe, because if Uganda's not safe, then the UK is not safe, for example, just using it as an example.
That's exactly right. And if you think about where the variants that have caused subsequent problems have come from, they've come from Brazil, the UK, South Africa, and India. 4 places where the pandemic raged out of control. Okay?
Yeah.
It just makes obvious common sense. If you've got lots and lots of the virus about, there are just more opportunities for it to mutate. So if we leave large parts of the developing or the less privileged parts of the world uncovered, we are going to just build up problems for later, because the virus will wash through them again, and we will be dealing with a new variant in another 4 to 6 months' time that will be meaning we're all back to square one. So we're not safe until all of us are safe is the right slogan.
Can I just ask you, Mark, just to make comment on, we talked about children and vaccinating, and we've heard what you said, but one of the things that's been in the media in the last few weeks, and because it's in the media doesn't necessarily, it's the truth, but because it's in the media, is that there's been some narratives and some discussions that children who live with parents who might be clinically vulnerable, there may be greater strength in vaccinating those children to protect their parents, for example, or grandparents. Is that, do you think that's reasonable, or is that extrapolating something that's not quite there?
No, in fact, that's exactly what JCVI pivoted to yesterday.
Oh, right.
The Joint Committee of Vaccination and Immunisation updated their guidance and are now accepting that we will offer vaccination to vulnerable groups and extend that to include children who live with vulnerable parents. Now, that's by the Green Book, and so there's going to be some questions about where the lines are drawn categorically, but I think the idea is now out there, and so that is the next phase of what we do.
And I don't want to put you on the spot here, Mark, about policy and stuff like that, because you talked about parents. Would that include, because I know it will come up, particularly with our patient population, PH field, grandparents, say children who meet grandparents, because one of the biggest impacts of restrictions has been on that sort of more older population and being restricted from seeing families. I'm not putting you on the spot. Do you think that would include those?
So we've only had the outline of their decision yesterday, but my understanding of the outline is it's who you live with. So if you lived with your grandparents, then I would expect that to extend to it. If you don't, then it may not. And it may be that time overtakes us, that as we are arguing about exactly where the line is cut, that at some point in the next few months we just move to vaccinating all kids over 12. And I wouldn't be very surprised if that happens. And I think there's a conversation that needs to happen with parents out there to prepare them and for them to start to think about how they would wish it to be done. And again, this will all be voluntary. And I think with the children in particular, we need to be especially sensitive because it is more complicated.
Okay, yeah, that's really helpful. One of the, can we just talk, and I think you mentioned at the beginning about the long-term effect of COVID, those that have had COVID, because some people will have had, and we may know friends, family, etc. long COVID, what it is and what we're doing about that.
Yeah, so that one is a thorny issue, and it's a thorny issue because it's still in evolution. So the the evidence is still is changing, and I think it's important to acknowledge upfront what we don't know. So what we don't know is what the long-term outcomes are going to be, because we're still only really a year and a bit down the line. But what we do know is that after being discharged, in particular if you were hospitalized, that a lot of people are continuing to have serious problems in the short and medium term, and about a third of patients get readmitted to hospital within 3 months. About 10% of patients admitted from the first wave died within 3 months of discharge. And a significant proportion, anywhere up to about 80+% of patients, are reporting persistent symptoms at 3 to 6 months. And those symptoms are diverse, they're quite complex. In fact, some patient-led research defined 200 symptoms associated potentially with long COVID. So it's a really complicated area. And as a really complicated area, it's going to take us a bit of time to unpick it. And it's also going to take us longer to then figure out how to treat it. So the first thing is, this is complex, and I'm really sorry that we don't have treatments ready yet. I'm personally trying my best, because we've set up a big study where we're going to recruit 3,000 people and trial some drugs to try to reduce the frequency of those complications. That's the Heal COVID study. But it might take a while for us to unpick all this. On the positive note, I run a clinic, and I see patients. I see the worst and sickest patients, because by definition, we look after the patients who are on ECMO, and ECMO is the artificial lung, basically. And I have been heartened and moved by the journey that patients have been on, and that is a journey of improvement. Now, they are all still telling me about the consequences, and those consequences are not small, and they're diverse, from mental health to physical, from respiratory to all sorts of weird and wonderful systemic problems. But most of them are getting better, and most of them are actually incredibly positive. So if you're out there suffering from long COVID, I think there is some hope for you. There is some heart to take. Other people have been on this journey. I've seen a lot of them, and I've spoken to them in the clinic on a kind of 3-monthly basis, and seen the trajectory. And the trajectory is mostly a trajectory of improvement. Where you'll end up eventually, I can't tell yet, but please hold on to that, because I've seen it, and I deal with it on a weekly basis. Good.
The question that's come to mind, and it almost feels like I'm jumping to a different area now, but it is about vaccines and stuff like that, because we're going to we talked about booster vaccines and things. What about the flu vaccine in the context of booster vaccines? I mean, can you do that? Can you, because people will be concerned about that type of thing, and flu?
Okay, so that I sit in the data safety board of another study that's asking us that exact question. It's not reported yet. The early suggestion is that it's certainly is not a problem, and there may be an added benefit from having the two vaccines close together. So go and get your flu vaccine. You don't have to schedule at the same time, but having them together is almost certainly safe. And there may be data coming out soon to tell us whether or not it then boosts the performance of either or both vaccines.
Good. So it's very safe. And that's good, because again, the media's talked about, and sometimes it almost feels unhelpful, or rather than encouraging people to be cautious, that we're going to have a big impact of flu this year because we didn't last year. Does that make sense to you? Does that sound right, or is it just?
I'm afraid it does, and we're already seeing some of that filter through. So there's a lot of kids viruses out there in particular, so things like respiratory syncytial virus or RSV. We're seeing a lot of non-COVID pneumonia and respiratory infections in the hospitals and in the clinics. And so I wouldn't be very surprised if we do get a double whammy with flu. So it is really important, particularly for the PH patients who may be vulnerable, that they don't forget about the flu vaccine as well as the COVID vaccine.
Okay, so just thinking about tying these things together then, Mark, going forward, I'm sure we'll have another sort of InfoCast meeting. This could be talk about trilogy. I don't know. We could have 10. I don't know what the thing.
Well, there are 9 Star Wars.
There are 9. Yes.
We could maybe aim for.
Yeah. It is. It's one of the silver linings of COVID, because we've got time. I've actually seen all the Star Wars films now and sort of understood them now. So there is some benefit with that. Just going forward, Mark, what would you say for between now and the end of the year, in the context of vaccines and all of us living and getting on with things? And this, you already sort of alluded to, the use of freedom is a bit of an unhealthy phrase, but yeah, the next 6 months.
Okay.
You know,
so bear in mind, I'm a Calvinist, pessimistic Scot. So anything I say, just filter it through who I am. But I think we need to just continue to be cautious, and so we need to define what cautious means. So for me, cautious means continuing to mask when you're in enclosed space with other people. It means continuing to do the hands, face, space. It means thinking very carefully about social interactions, and when you're doing them, try to do them outside, because that's pretty safe. It doesn't mean cloistering yourself in a room and staying away from the world, but it also doesn't mean dropping all our restrictions and dropping all of our changes in personal behaviour and just going back to normal. I mean, I'm not doing that. And in fact, at the moment, I've kind of reduced my social interactions in the last week or two because there's just a load of COVID about. And rather than increasing them, I've kind of gone the other way. I'm still going outside. I'm still, seeing people, but I've reduced the amount of times that I'm putting myself at risk, and I think that's probably a reasonable way for a pulmonary hypertension patient to approach it as well.
Mm-hmm. Mm-hmm. Good. So you're on holiday soon in the 24 hours, so you need to rest. I mean, listening, you're on all these committees, these safety committees, Mark, things like that. So you and your family need to keep safe. And I just again want to say thanks to you and your family for lending us on these 3 occasions. It really is helpful, reassuring. It's honest. It cuts through some of the confusion that we get in the media and social media type thing. Just about, I think the final thing, but your wisdom about seeking the best advice. What is it? Is it good to listen to lots of media? Where to go and get up-to-date information? Things to avoid? What would you say to a patient in clinic? They say, I'm just hearing all this thing all the time. It's driving me mad.
It's tough, isn't it? I mean, I think the great thing about our patient group and our community is that we're pretty tight, and so I think we're a good protocol actually for a lot of these things. So I think lean on us. I'm sure in Sheffield it's exactly the same as in Cambridge. We're very happy to take questions when patients have queries and there's any grey area. Try not to read so much of it is my real advice, because I mean I went through a little period of being off all of the social media for a month or two, and it helped me enormously. I'm now finding myself doom scrolling a bit, and it really does affect you. And I'm quite good at picking out the right voices, but even me doing it, it can get quite depressing, and you can end up reading a lot of very conflicted advice that is kind of polarized, and it's there's a little bit of the loudest people are the ones that get heard. So you end up thinking it's one thing or another, and often that's not the case. Often the answer isn't shut yourself away in a house or go to a nightclub. It's somewhere in between. It's and those in between voices often aren't very loud. So my strong advice to you would be dial it down. Dial it down, and if you've got questions, if you trust your GP, use your GP. If your GP relationship isn't quite as rock solid, then the PH centres are always here.
I mean, obviously, I from our perspective as well, from the PHA, we make sure that our web pages, particularly on the COVID, are updated on a daily basis, and it's the feedback from people like yourselves. So I'm bound to say, but we are updated every single day. The team are really good at doing that. And
can I give you some feedback then, since we're in the feedbacky move? So I've had some amazing positive feedback about these interviews. I think the reach of them is quite astonishing, and that really is a credit to the PHA and to you and to the way you've run them. And patients really appreciate it. It's been a really powerful resource you've built, and so thank you for letting me get involved. It's really important at this time that when there's so many different voices out there, people get the opportunity to hear from you and from us. Yeah, that's helpful. Yeah, it's about building trust as well, isn't it, Mark? That it's consistent in its trust and things like that. So excellent. Do have a good holiday, Mark.
Okay, behave yourself though. Stay safe.
Thanks,
Yeah.
Ian. You too.
Yeah. Okay. Cheers.